Hi.
Hi. Do
I
you
see
feel
my background is blurry.
your background is a little blurry? Yeah.
Okay, good. No, I did it on purpose the other day because I realized you could do it.
How do you do it? How do I change my background to?
You have to, is that in your house? It's so pretty.
No.
Where is this? Wait a minute. Hold on. Raul showed me how to do this.
Is it on more?
Hold on. It's on.
Screen.
How did I do this? If you go to, okay, go to video, like the little up arrow thing.
Choose virtual background.
No, go to video settings.
Okay.
Okay, wait. Okay, and then it should open up like a big menu and go to background and filters. And you can choose blur.
Background and filters. Oh, blur. Am I blurred now? I guess I am.
Yeah.
Perfect.
I kind of like it.
I love it.
Yeah.
I thought we should put up the talk, but I don't know how to do that. Hi.
Oh, hey, Danielle. Oh, you're on mute.
Good.
Yeah.
Lisa, I love your background. Oh, Melissa,
we're the same. She just taught me how.
Word. I know.
My husband showed me how to blur the other day, and I was like, "Ooh, this is much better."
I feel like I should know how to do that.
Yeah. So you just go to video, like the little up arrow, and then you go to video settings, and then there's another on the left side menu. You go to background and filters, and then blur is an option.
Wait, hold on. Video in my. Where am I? If I'm on my Zoom screen, you mean? Is it in Zoom?
Yeah, you know how it's like mute and then it says stop video and there's like the little camera and then there's like an up arrow.
Yes.
So if you hit the up arrow, then do you see video settings?
Yes.
Okay, then you go and then on the left side menu, you should see background and filters.
I don't know if I have that. Hold on. Video. So funny how we really focus on the important things.
Yeah.
It's so important, the background. I always worry about it.
Yeah.
Okay. I think I did it. Blur, right?
You're blurred.
There you are. You're blurred.
Perfect.
Look at us. We're all in sync.
There you go.
I know. I got a new computer because my old one was torturing me.
Got a fancy.
Yeah, I upgraded. Though I had a desktop, which was so much better for clinical work, like a big, and I'd still use that for my sessions. But when I'm presenting or doing talks, this is much better.
Yeah.
Yeah.
So glad you're here, Danielle.
I know it worked.
It works. It takes so much time and effort to like just get dates. It's unbelievable.
I know. And I'm the programming chair for Scarsdale this year, so I am well aware how torturous it is.
I didn't know that. Wow.
Yes. It's been, we had Ken Ginsberg in the fall, who was amazing. Did you go to that? Or no, I guess, Lisa, you're not.
No, I am. My daughter's there.
Yeah. We had Ken Ginsberg in November. That was amazing. It was really.
I didn't. I feel like we had something conflicting that night. I remember when it was, but I had something else. And it's just so hard to like, at 7:00, with patients and kids and things we have for Sacred Heart, it's like impossible.
I have my kids locked down at the moment. I was like, no one's coming up here. I'm like,
it's so hard,
Yes. Do you live in Scarsdale, Danielle?
I do. So should I make sure that you guys can see my PowerPoint before?
Yeah,
go for it.
Let's do that because
we'll manage the questions for you, Danielle. So don't worry about that part.
Okay, great. How many people are usually?
We had like 40 signed up, but I think the most we usually get is like 65, right, Melissa? Or have we gotten more?
No, that's kind of been like our top for Zoom events, which is more than in person, actually.
I know, it's a weird thing, right?
Yeah. It's so much easier though. I mean, I feel like
it's harder to present though.
Yeah.
Yeah.
Right? Have you guys
on Zoom than you mean on web. Yeah, it's very awkward on webinars. I know.
It's awful.
Yeah. It's
Sorry.
hard, right? Without the feedback, without seeing people. And but seeing people on Zoom is also hard because I find people are like they make strange faces. Oh, there you go.
Are you guys seeing that? I just want to make sure this is the right one.
By the way, when people sign on, I saw someone sign on and then jumped off. Like they'll just sign on, just FYI.
Okay.
It's not like a waiting room situation where we have to let them in. Like they can.
Oh, really?
Yeah. I just realized that because I saw someone from our school signed on.
Okay.
So just heads up.
Okay. So you can't see that anymore. I'm sharing my screen. Do you want
now now we see your screen, your computer.
All right, hold on. Okay, so let me get rid of that. Nobody wants to see that. Hold on.
I relate, Danielle.
It's so bad. Hold on.
You think you'll talk for about 45 minutes? Is that too long?
That's what I'm thinking. Hold on.
Okay.
Get back to me.
We'll try to end by 8:10 at the latest, right?
Yeah, I think so. And then I'll just start by saying hello, Danielle, like 2 seconds. And then Lisa will introduce your bio.
Okay.
And then you can take it away and then we'll alternate on questions.
Okay. Now, sometimes when I'm doing my own questions, like I'll stop along the way. I'm happy to hold until the end, unless you guys think there's a pressing question.
No, I would hold until the end.
Okay, fine.
Yeah.
Okay. Fine. Okay.
And we'll hold the questions till the end. Even if they pop up, we'll just ignore them. Yeah.
Good.
I think otherwise it's just too distracting and it's easier to flow just to kind of get it.
Right.
Right.
Yeah.
Okay.
Yeah. Do you want me to say anything about specific schools you present at, or you're good with just, I didn't know if you wanted me to mention Sacred Heart or anything.
If you want to, I speak at Nightingale. I'm, sort of at Grace Church. I'm sort of like on the whole
circuit.
Exactly.
But I think you say it that you hear, that you lecture to health professionals on the topic of eating disorders, departments.
Yeah.
Yes. And that you teach about eating disorders to middle and high school students throughout New York. Yeah. So you cover it.
Yeah.
Okay. So when are you going to be at Sacred Heart in the city? Are you going?
I'm doing virtually there next week.
Okay.
I snuck in an early lecture with them in like October before it was like when we were just open then I had I feel like their middle school lecture, we just pushed probably till May. And then the parent lecture turned virtual, for next week. So, which is fine.
Mm-hmm.
Mm-hmm. But do you know Kim Napier?
I feel like I do. I don't know her personally, but I think is she a psychologist or a social worker?
She's a psychologist. I love her. She is awesome.
Maybe she went to NYU. I think she might have gone to my program. And I think I've known her. Has she been there a really long time?
No, I feel like she's like
maybe not. I don't know.
Yeah. She's our age, maybe a little younger, actually.
I know her from somewhere. Where does she live? Does she live in New York City?
Lives in the city. But she just, she used to work at CBC, Alec Miller, the DVD.
Yes, we both do, Melissa.
She used to work there like years ago. Maybe she did her internship there or something, or did like a postdoc there or something.
Mm-hmm.
Because when I was presenting there was a DBT person there from, what is it? CBC, cognitive behavioral, whatever,
Yeah.
We just had a Scarsdale, like somebody presented to us from there a couple of weeks ago on anxiety. It was really good. She was good.
Really?
I can't remember her name.
Like an in-service, Danielle, or for families?
It was for the child program. So it was like for just, aiming towards the younger section of Scarsdale. So it was like for preschool and the little school, but she was excellent, actually, just about anxiety and, how to manage kids' anxiety and like tips and tools kinds of thing.
Oh, that's so great.
She was great. It's recorded if you want it. And
is it? Oh yeah, I think we'd both love to see it. Where can I find it? Is it on the Scarsdale website?
Probably not. You probably have to email Meg Simon, the PTC chair.
Okay.
She'll send it to you, or the president.
Okay. I will. I know I always intend on doing everything, and then nothing is ever.
I know.
It's so hard.
The reason I am doing it is because I am running it, or else I would be hearing about it.
Is that a 1-year position, or do you have to?
Yes. And it's so much work, but it's only because I'm close friends with the president. So she told me I had to do it. Oh, and Atara's doing it with me. Atara's doing it.
Oh, Atara's doing it with you.
Yeah, with me.
We both know Atara.
Oh, you do? She may be getting on. I told her to get on the Zoom.
Oh, she should. Oh, my daughter is FaceTiming me. Hold on one second. This is the last I'm giving them.
Different look.
Isn't it so funny, this Zoom world? I mean, things are just,
I know.
It's unbelievable.
It's really crazy. It is much more, I really much prefer talking in person.
Completely.
I'm all about like interaction and feedback and like, what's the vibe? And like, it's hard.
It's so hard to tell. I know I've done a few webinars too, and it's just the lack of like interaction with people. It's really tough as a presenter.
I know I've noticed that you'll notice this too, but I start to say things like I'll say, right? While I'm talking.
Like, anybody out there?
Right, like, come on, guys, like, get with the program. Right? Don't you agree with me?
I'm like, right. Exactly.
But I don't know. I find Zoom to be really awkward because so many people give such dirty looks on Zoom. And I feel like they just kind of like, I don't know what it is, but like a lot of people, or we find, Melissa and I always notice, like sometimes people give awkwardly, they smile awkwardly. It's like someone told them like, smile now. And they're like, yeah. It's really funny.
Really funny.
Okay, wait, people on.
I bet with school stuff, some stuff will never go back, right? To non-virtual. Like these will never go back.
I don't think they'll ever go back. Parent,
well, why would they?
Yeah.
Because attendance is higher. It's just so different. It's so weird.
Yeah.
Here we have attendees, ladies.
Okay.
It's not quite 7, so we'll give people a few minutes. People are trying to make their way.
we'll get started in just a minute. We're just waiting for a few more people to sign in and we should get started. Welcome, everyone.
Okay, everybody. So I think we're going to go ahead and get started. It's always a little bit funny on Zoom, figuring out the exact right moment, but I think we're in a good spot to get going. So welcome to everybody out there. My name is Melissa Otero, and I'm a lower and middle school psychologist at Sacred Heart. And we're so lucky and so thrilled tonight to have Danielle Shelov with us for this incredibly important and timely talk. And Lisa's going to introduce her in just a moment. And I'll just mention that as we go through tonight, please feel free to put any questions you have in the chat. There will be some time at the end for questions. So just as anything pops in your mind, please put it in there. And we will do our best to make sure that all of those questions get to Danielle.
Thank you, Melissa, and welcome everybody. Welcome, Danielle. We're so pleased to have you here tonight, and we're so fortunate to speak about this very timely topic. I'm Lisa Schwartz. I am the psychologist in the high school, and I would love to introduce our speaker tonight, Dr. Danielle Shelov. She attended Yeshiva for Kof Graduate School at the Albert Einstein College of Medicine. Dr. Shelov trained at Montefiore Hospital in family medicine, Bellevue Hospital in neuropsychology, and at the Anxiety Disorders Clinic at Columbia, the Psychiatric Institute. Dr. Shelov completed her psychological internship at Maimonides in Brooklyn. Dr. Shelov received her postdoctoral training at Columbus Park Collaborative in New York City. She served as a supervising psychologist and also as a certified yoga teacher, which is awesome, developed the yoga program adapted for patients in the center. Dr. Shelov lectures frequently to health professionals on the topic of eating disorders in the departments of pediatrics, psychiatry, and adolescent medicine. Dr. Shelov also frequently gives didactics in eating disorders to mental health professionals in social work, psychology, and education. Dr. Shelov also teaches about eating disorders to middle and high school students throughout New York City and Westchester, as well as speaking with parents and educators in the area of eating disorders. Dr. Shelov maintains a private practice, which is called Shelov Psychology Group in New York City. And I do want to mention that she will be speaking to our high school students at the end of March. So that's something that we very much have to look forward to. Originally, we were going to do it in person, but we had to we had to move the date to secure the fact that we could do the in-person work. So please keep that in mind as you listen to her speak, because she will be speaking to the girls later in the school year, and we're very excited about that. So welcome, and we're so pleased to have you here.
Thank you for the introduction. I really appreciate it. And I'm really happy to be here. And this is my first time speaking with Sacred Heart in Connecticut. So I am really excited. I do a lot of work in the city at the Sacred Heart there. So I'm happy to head north, which I live in Westchester. So it's a nice change for me. So why don't we just dive right in? If that works. Let's do this is the worst part of the talk for me, which is the technological piece. So I'm going to share my screen now. And let's make sure that that works. And if you guys let me know if that's up, we good to go? Okay. All righty. Okay. So to begin, This talk is really about understanding food, the body, and the mind. And the field of eating disorders really focuses on the fact that these are all connected. Hold on 1 second. For some reason, it's not letting me. There we go. Who I am is Shelov Psychology Group, as I was already introduced by Lisa, by Dr. Schwartz. So thank you very much for the introduction. And just to basically know, like, who is this person talking to me, telling me about my daughter? And I have just been doing this for a long time. I've seen a lot of eating disorders in my day. And so I'm very aware that each one is unique and they all cannot be managed the same way. So if I do anything, it is I approach eating disorders from that perspective. So I think, especially over the course of the pandemic, I think it's been very important to reshape the way people view eating disorders, because I think most people believe that eating disorders are really scary. I find parents come into my office really afraid when they think their daughter has an eating disorder. For the purpose of this talk, I'm going to talk about girls because this is a girls' school, but be aware that all of these, everything that I say really can apply to boys as well. I find often that people feel a lot of shame. They want to keep it a secret. But the reality is that the opposite of eating disorders is true, is that it is nothing to be ashamed of or afraid of. They can be treated and they can be healed. And ultimately, and I'll get into this more throughout the talk, but they really illustrate a very strong coping mechanism in your daughter, right? So it means that she has figured out a way to manage her anxiety that she's figured out on her own. It just has gone awry, basically. So our job is to help figure it out with her. So, hold on 1 sec. Sorry, this is, okay. So this is about shifting the frame. So how do we view eating disorders? How do we shift them from being scary to something that we can treat and something we can examine and something that are looked at per individual? So the number one most important thing about eating disorders is that they are driven by biology, right? And I think that for most of us, we sort of think about eating disorders as vanity, or they think it's entirely about society or being thin. When the reality is that the biology of eating disorders are about hunger, right? And so hunger is a primary drive. So I know we learned about this a long time ago in biology, right? But primary drives are innate needs that are necessary for survival, right? Hunger, sex, thirst, these are all things basically that are how we as a species survive and grow. And as a human, we have our need system that is based on a hierarchy of needs. So that means whatever is consistent with our survival, whatever we need to survive, we're going to attend to first, right? So that is why hunger becomes so important and is so prolific in terms of understanding eating disorders, right? So that is something I want you to remember for this whole lecture, which is that what is needed for survival comes first. So if we are hungry, that is what we are going to be focused on. Okay. So because we are animals and we have to focus on hunger when we're hungry, right? What happens when we restrict our food, which is ultimately how eating disorders begin, right? It can be an innocent restriction. It can be a diet, and we'll get into more specific triggers in a little bit. But the reality is that if we mess with something like a primary drive, like a survival instinct, we are going to focus on meeting that need, which is hunger. And let's just think about it to bring everything personally, which is really how we learn, right? Suppose it's January 1st and you decide you want to go on a diet. That week, how hungry are you? That's just how we operate. Once we start to restrict something that is a drive, all we're going to be able to do is focus on it. So to make sure that we remember that we are animals, right? And we are in the animal kingdom, right? And sort of why eating disorders don't make any sense from a biological standpoint. And I always use this example. So there's a lion, right? Walking by a zebra. And do you think the lion ever says to himself, like, you know what, I really shouldn't, like, I really don't need to eat that right now. I've had too much. Absolutely not. Because a lion is going to eat when it's hungry. And if it sees the zebra when it's hungry, then it's going to be totally on board with eating the zebra. There's not going to be a should system built in, right? And so what we start to realize is that by inhibiting our primary drive, this is all that we start to think about. But the other thing that it does, right, is that it turns on a system within us that thinks that there isn't any food around, right? Because it's unnatural, because lions will naturally hunt zebras, humans are supposed to naturally eat when they're hungry, right? But if we don't do that, then it tricks our minds into believing that we are in a time of famine, right? And if we believe that we're not eating because food's not around, then we will no longer eat when we're hungry. We will wait to eat until we're absolutely starving, right? So our hunger and fullness gets totally dysregulated. And if there's any questions that come up that we think are really pressing, just let me know. But if not, I'm just going to keep going through this. Okay. So the way we have divided eating disorders up in the clinical world is that there are 5 primary eating disorders. I'm only going to touch on 3 of them, which is anorexia nervosa, which is probably the most famous eating disorder and the one people are really worried about, along with bulimia. And then there's binge eating disorder. And then there's something called OSFED, which is sort of when you don't really meet any criteria for any of them. And another one is called ARFID, which is much more of sort of like a texture related disorder that I'm not going to get into. If there are questions about it, feel free to ask in the chat, or Dr. Schwartz knows my email. We can do it that way. Now, the other eating disorder that keeps coming up that is new and not yet in the book, basically, is called orthorexia. And orthorexia is a hyperfixation on health. And so I will get into that because if anything, I see that to be the most prevalent these days. And I think it will be classified in a matter of time, basically. Okay. So anorexia nervosa, I think, really speaks for itself. It is a consistent and persistent restriction of food, which leads to a very significantly low body weight. Along with it comes an intense fear of gaining weight or of becoming fat. And also it's accompanied by body dysmorphia, which basically means that the way the anorexic sees their body is not the same as we see it, right? So even if an anorexic looks at the scale and knows the weight is low, they still feel that their weight is high. So there's a dissonance between reality and what they experience. The other sort of like big gun, I think, is bulimia nervosa, right? And so bulimia it's similar to anorexia just in the fact that it's a manipulation of food. However, this occurs with a recurrent, inappropriate compensatory behavior in order to prevent weight gain. For bulimia, behaviors occur on average at least once a week for 3 months. And also this whole body dysmorphia concept is related, meaning they see something that other people don't see. But the other thing about bulimia is that there's a compensatory behavior that can be purging, which is probably the one people know the most about. But compensatory can also be periods of severe restriction, and it can also be overexercising. So all of these things make up a compensation. And then binge eating disorder is the other one that's still in the manual. And basically it's similar to bulimia without the compensatory behavior. So it's eating large amounts of food when you're not hungry, real distress around the engagement with food, again, occurs at least once a week for 3 months, usually much more frequently than that. There's a lot of shame involved in binge eating, a lot of self-disgust and self-loathing, but again, no compensatory behaviors. So there's no purging, there's no restriction, right? And there's no over exercising. So that's really what is markedly different about binge eating. So orthorexia, which is new on the scene, and I think, honestly, I do believe is the most difficult to treat because it's not about caloric restriction. It's about compulsive ingredient checking, meaning only eating healthy, pure foods, right? So if your daughter, or if you notice that somebody is looking at ingredients compulsively or only eating something that is completely organic or grown on a farm, or if they have to know where the meat is raised in order to eat it, right? This obsessive following of food and health social media accounts, right? Not as much body image preoccupation, though I do find it is present, but a real just obsession with health, right? So that is new, and I think will be classified the next time the DSM comes out. So I always call these the fake facts of eating disorders that all parents sort of come in my office with, which is that how can she have an eating disorder? She's not so skinny, right? That's really not that relevant, actually. Thinness is not the criteria for an eating disorder. Only girls having an eating disorder is not real, and that they are based on vanity and control. These are old myths that are very important to let go of, because it means that tons and tons of young girls will go missed. And I think that that's really important. And these are the unknown truths. Hold on. Is that eating disorders are actually genetic. And I have a whole sequence on this because that is critical. The biggest symptom of eating disorders is not the weight. The biggest symptom of eating disorders is about the thoughts, right? So how much time in a given day does an individual spend thinking about food and body? So for any diagnostic, that's what we're curious about, much more than about weight. And also 15 to 25% of people diagnosed with eating disorders are boys and men. And by the way, they usually have the highest number of undiagnosed because people assume that it is not happening for boys and men. So I have a sense that that number is far higher. All right. So this is when we build into the layers of the eating disorder. So in the eating disorder community, we usually talk about the 4 Ps of eating disorders. So the layers are the predisposed, meaning the genetics. Then we'll talk about the precipitating factors, meaning the triggers or the catalysts. Then we'll go into the perpetuation factors, meaning why does this keep going? And then there's the prescription or the treatment plan. I don't really get into the treatment plan in this talk because I think we're really laying the groundwork for what people have to look for and what is causing the eating disorders as opposed to how we're treating them. I think that's much more like a follow-up talk. Okay, so the genetics. I think that parents and families and humans in general have no idea that there is a genetic link for eating disorders. Individuals with family members who have an eating disorder are 40% more likely to develop one than control families. Now, this means that eating disorders have a biological basis, right? So that means that even if somebody, you wouldn't think would have an eating disorder, if they are something called genetically loaded for an eating disorder, the likelihood of them developing one is higher. So that's something that we need to remember, just like depression, just like anxiety, just like schizophrenia, which is biologically based, eating disorders have a genetic component. The interesting thing is that eating disorders come along with OCD, rigid perfectionism, and all types of anxiety, including separation anxiety. So meaning that eating disorders don't cause OCD, and OCD doesn't cause eating disorders, but they usually come together, right? They run along the same track. So that's a really important detail to remember, because usually people that have eating disorders are quite rigid, have instincts towards perfectionism, and our OCD. Now, why genetics is so important in all of this is that it rejects the myth that eating disorders are simply about vanity, right? Because if it's in our biology, then it's much harder, right? Then it's something that we cannot control. So precipitating factors, meaning triggers. So a lot of these sort of come under the umbrella of trauma, right? But so there's two different ways to look at this. Eating disorders also develop in people that don't have the biology, right? So that's important. They can develop in both, but both biologically loaded and non need some type of precipitating factor. The traumas that we see most frequently are the loss of a loved one for a teenager, or younger child, or even someone in their 20s and 30s. For younger kids, bullying can be a trigger. Any type of difficult transition that these kids can face can be a precipitating factor. And the other thing that I think is really important is that any kind of diet can be a trigger. And the reason why that goes back to the animal kingdom that I was talking about, which is that if somebody, particularly those that have the genetics, if they go on a diet, right, they can trick the body into believing that we're in a famine, right? And so once that happens, it becomes difficult to untrick the body and have them believe that it's just a normal time, right? So diets can sometimes inadvertently trigger an eating disorder. And everyone has a lot of questions about that, and I'm happy to deal with that at the end. And then the perpetuating factors, right? We all live in a very, very high-powered world, right? We are in high-pressure schools. These kids are worried about college from an age that is so young, right? So I think stress, and more stress is huge in terms of keeping these factors going. The one piece of advice that we give to anybody that is discharging from an eating disorder treatment facility is minimize stress, right? Because remember, eating disorders are a way of coping with stress. Stuff at home, right? A lot of fighting at home, just stress at home, that can perpetuate. And obviously, I don't even have to say it, is, social media. Social media means that there is nothing private in these girls' worlds, right? Every single thing they do is visible to other people. They are looking at a curated reality of their friends' lives that are impossible to keep up with. And so once the idea of thinness, of body image, of food preoccupation enters their social media world, then we are dealing with something that is really difficult. I mean, the whole Facebook whistleblower was based on eating disorders. That was the fake profile that she brought in, was a young teenage girl struggling with eating. So that's really important to remember. And that within something like she registered that morning, by the evening, she was already in unauthorized chat rooms talking about how to lose weight and keep it off. So that's how quickly this stuff moves. And of course, peer pressure, right? So how their friends look, what's happening with them, right? There is nothing that you or I can say that holds as much weight as what their friends say, right? And so one diet in a group of friends can be problematic for the whole group, right? So I want people to keep that in mind as well. And I get this question all the time, and I really understand it, which is that, okay, so we've identified a problem, right? It looks like there's been some precipitating factors, right? We understand what's going on. This girl, maybe she's dropped a lot of weight. Maybe you notice that she's, really struggling to get weight back on. Why can't she just eat more, right? If we know there's a problem, just eat more. But again, and I keep going back to this, and I am sorry to be repetitive, but that's because we have unknowingly tricked our minds into believing that it shouldn't eat, right? Not just shouldn't, but it can't eat in order to survive. Right. And the only way to break this sort of famine or scarcity thought process is to resume normal eating. But our minds are the strongest organs that we have, and they run the show. And they are saying, you know what? those people are telling you to eat, but I'm telling you that in order to survive, we're not going to eat anything. So it becomes the voice of the eating disorder against the voice of reality, right? I use the hijacker as an example, that basically the brain, as we know it, has been hijacked, right? Because it's basically saying, I should not eat in order to have a life, right? And that's what we're fighting against. Okay, and then this is sort of the next piece of it, right? Which is, so how does all this implicate feelings, right? And so why did feelings get involved in the whole eating disorder situation? Why don't we just send these girls away and have them eat and come back? Because what happens is, because of this hierarchy of needs, right? Inadvertently, we discover that if we're thinking about food, we don't have to think about feelings, right? Because if we're thinking about food and we're consumed by that, we don't have time or room to think about, I'm angry, I'm sad, I got cut from the track team, my friends aren't talking to me, everybody was hanging out at so-and-so's house and I wasn't there, or I'm looking on social media, or, I'm looking at my Snap Map and I'm seeing everybody's at one house and I'm not there. Right. So in order to diminish all of that anxiety that is coupled with natural teenage growth, we can think about food and we don't feel as messy. Right. So food gives us something else to focus on instead of the ups and downs of just being a teenager. So I really view eating disorders as the intersection of the mind and the body, right? So because of all those precipitating factors, we learn without wanting to that controlling our food makes us feel better, right? And again, because it's primary, controlling our food then messes with our biology and psychology. And we can no longer eat when we want to eat, and we have no idea when we're hungry for anything. Right. But the problem is that we're stuck in a loop, right? And we're hungry and we want to eat, but then we feel like we shouldn't eat. And then all of a sudden it also feels good to not eat, right? Because then we don't have to feel all the messy feelings. So as a parent, when we're looking at our child and we feel frustrated and we feel upset that they're not just eating, I want us also to have empathy for how much internal work is happening, right? The one way I connect so often with my teenage girls is I say, my patients, by the way, I have boys, but the one way I connect with them is I say, you must be so tired, right? This is really tiring. All of this logisticking and thinking about food and then not letting yourself eat enough of it is such a tiring thing. So anytime we lose our sense of empathy, it's a really good thing to help us regain our center. So the relationship between perfectionism and eating, because that's complicated. Like I said in the beginning, eating disorders are coupled with rigid thinking, OCD, and perfectionism. And they're comorbid, right? They come together, they don't cause each other. The problem is that they reinforce each other, right? So if you are instinctively rigid, or if you are instinctively lean towards the perfectionist side, then it is going to be much easier, right, for you to be really rigid and perfect about your food, right? So it's almost like you are born with this reinforcer, right? And so it's just not doing you any favors. So I want you to think about the whole constellation of symptoms instead of just looking at them as really sort of causing each other. They're not causal, but they do impact each other. And this is the universal symptom. And this is really the other biological piece of this that is so confusing, which is that the other way that human beings and animals have been able to reinforce not eating, right, when it thinks it's in a time of famine, is that literally when you are hungry, you start to see your body differently, right? So messing with your food, which is how I usually frame it to families, alters the way you view your body, right? We don't really know why. It's often why medication is helpful, actually, because if you think about it, medications help rigid thinking, they reduce distorted thoughts. So we'll never know specifically why it helps, but there is some level of distortion that this is helping with. It's also helping with rigidity. But when you have an eating disorder, and even when you don't, you start to feel fat, right? You actually embody the feeling of fat. But the reality is fat is not a feeling, right? There's plenty of feelings on the feeling wheel. There's angry, there's scared, there's sad, there's joyous. Fat is not one of them. But in the language of an eating disorder vocabulary, fat is number one. I had a good day. I felt thin. Today was really hard. I felt really fat. Has no bearing on what I see in your body. It has only the bearing of how you feel in your body. So this distortion also reinforces the eating disorder, right? Very hard to force yourself to eat when you feel fat, right? Almost impossible. And for whatever reason, they've done tons of brain imaging studies. What they show is that in the brain of an eating disordered individual, this is the last symptom that heals in the brain, right? So if you're looking at all of the different neurons and the way what is lighting up when somebody is in an active phase of anorexia, and you see as they get better and better and better, that sort of like hotspot in the brain will get smaller and smaller. The part of the brain that lights up around eating, around body image, that is the last one to resolve. Okay, so I think that this is a really important part of the talk, right? And I think for so many people that come into my office, this is what needs to get addressed is, as a parent, what do I need to know? So first of all, what am I as a parent looking for, right? And this is what I tell my parents, which is that you're looking for a change in diet. You're looking for sort of weird specificities about food that weren't there previously. Like if all of a sudden your daughter shows up and says, I'm vegan, I'm only going to eat gluten-free moving forward. If they have this really exaggerated sense of healthy eating, right, that wasn't there previously, those are all really important factors to start looking at really closely. Then the behavioral things that I really like to watch for, which is all of a sudden, if your daughter refuses to eat with the family, if she says, no, I'm not hungry at that time anymore, I want to eat earlier, or I want to eat later. We don't like isolation around food. Look for a general sense of irritability. Like we all know what it's like when we're hungry and how irritable we are, right? And how we have less patience with everything. There is no difference in what your daughter is experiencing if this is what she is doing, right? She's going to be irritable. She's going to have less ability to focus. All the things that grown-ups experience, they do too, right? It's just because they're young, they have an ability to deal with it better, right? Especially in terms of workload. Obviously, you want to look for a drop in weight. I'll get more very specifically about what doctors and clinicians look for in terms of weight, but you want to notice that. Is there a significant weight loss? An increase in exercise or activity is really important. The other like sort of sneaky thing that I have just found so consistent over the years is that I find that my patients always need to read menus prior to going out for dinner or lunch, right? All of a sudden, what feels like I've just become a foodie, I've just gotten really into where we eat and what we want to eat. That is not normal behavior, right? Needing to read every menu before you go to eat and then saying you can or cannot go based on the menu, that's a symptom that I would like people to be aware of and start looking for. And the biggest thing in terms of, and by the way, this is not just eating disorders, this is for all types of anxiety disorders. Look for change. Right? Like if you have always had a happy-go-lucky kid and over the course of 6 months, if you notice significant difference, then you want to start to ask questions, right? Don't just let it go because like they're hard to talk to or they're irritable, right? Look at their mood, look at their food, look at their friendship circles. Have there been changes that you don't understand? Have they stopped talking to people? Have they made new friends? all of these things are areas where struggles with food can show up. Because it's important to remember, eating disorders don't really like it when people have friends, right? Because they have hijacked the mind and they want to be alone with the person so they can talk about food, right? A lot of times I sort of illustrate an eating disorder as something like a separate object that has like invaded the brain. That's how I want you to think about it, right? And also just look at your child's capacity for joy, right? Has that gone down? Has that changed? Right? Because that messing around with food will do that. And isolation just always comes up. So this is another massive question, right? What not to do, right? So as parents, do not focus on weight and food, right? Do not label foods good or bad, right? Label things like, are you hungry for that? Right? We do not want camps. We do not want people saying like, that's not good for you to eat, right? Now we're talking about, you know, a general sense of all food being good, right? And foods do not, again, have feelings, right? And we can't say, you know what, sugar cereal is bad. And if we're talking about a young kid, if I'm working with like the parents of a younger child, I'll say, you know, sugar cereal is not a great way to start the day. Why don't we buy it as a snack? But we don't want to label things good and bad. This is a hard one for parents also. I don't like it when there's a scale around, because if you're weighing yourself, if there's a consistent weighing of yourself, usually your child will do similarly, right? And if there's a scale available to them and they've started weighing themselves, then they will continue to do so. We do not want the number on the scale to be a measurement of how they feel, right? So if they start pairing the scale with, I had a good day or I had a bad day, then that can start a bad habit, right? And a bad association. Do not comment on bodies, right? As hard as it is, we just try to not talk about bodies. We talk about how wonderful people are, how smart people are, that people are different, that people can be happy at any size, basically. Allow desserts, right? Desserts are okay, but just make sure you have dinner first. And this is more for younger people, but do not use food as reward or punishment, right? If they do a good deed, they don't get a candy because of that, right? So right from the beginning, we don't want to pair food with good behavior. And so what does all this information mean for my daughter or my child, right? And so in so doing, I want people to look at the whole picture of their child, right? Even most importantly, not all girls can diet without consequence, right? So I know there are different bodies at different ages, but I would really be careful anytime a pediatrician or any person says, you know, your child really needs to lose weight, right? There are ways that we can navigate talking about food without it necessarily being about weight, right? The other thing is that to remember, like we talked about, is that if your daughter decides to go on a diet, right, that can inadvertently trip an eating disorder or precipitate one without meaning to do it, right? So the best way to avoid issues with food is to normalize food. When people say, I don't want to eat dinner, you say, are you full? Are you not hungry? Keep consistent food paired with hunger and fullness, because that's why food exists. And that's how human beings are supposed to approach food. The other thing to remember, if we see something happening with food, we want to intervene early and quickly, right? Because before this eating disorder can get its hooks in, right, and start getting complicated with emotions, and people are learning how to feel better or feel worse around food, we just want to get their weight back up, right? We want to make this not being able to be paired with good and bad, simply get your weight back up. And then usually the preoccupation with food will lessen because they're not obsessed with being hungry. Hopefully all this information is feeding on itself and this is all making sense. Okay, and quickly, what does the clinician look for? So what am I looking for? And usually what are many pediatricians looking for when they come into the office? So when I'm talking about a weight loss, I'm also talking about a significant drop off the growth curve, right? So if you have a kid that's always been 90th in height, 40th in weight, right? If you come in and all of a sudden you see they're 90th in height and 20th in weight, that's something to look at, right? And even if they start dropping down on the weight scale, and all of a sudden, if they start to flatten out before they're ready to on the height curve, then that's something we want to pay attention to. If a girl has gotten her period and then stops getting it, that's obviously a huge red flag. Again, the rigidity of thought, right? Suppose you start talking to your daughter around food or around like, hey, let's try this restaurant. I want to try it. And she says, no, I don't want to go there. Or certain things like that keep happening. That's something really important to focus on. Also, any type of fixed belief that doesn't really make sense. Like I had one patient that was like, the only protein bars you can eat are Quest bars. I was like, why? It was just a little bit delusional, a little bit of an irrational fixed belief, but she believed the Quest bars were nutritionally superior, right? So that is something that you can look at, right? Just things that don't totally add up and aren't the way your daughter was. And again, the level of preoccupation, how much time. I will say to a patient that I have, how much time of the day are you spending thinking about food in your body? I will get charts back that say up to 95% of the day is spent thinking about that, right? And everything else is academics. So level of preoccupation just as much as weight loss. And also watch for sophistication of compensatory behaviors, meaning, is your daughter insisting on walking everywhere all of a sudden? All of a sudden, all she's doing is biking everywhere, right? If she's getting on the treadmill and she won't get off the treadmill and is figuring out how to study for exams while she's walking. If she asks for a walking desk, which is something that I've been exposed to over the pandemic. None of these are things that are normal behavior. And then the attachment. So this is always the big piece, which is when I say, okay, so when you come back and see me next week, I want you to just eat the way you did before. And if somebody is really entrenched in an eating disorder, that will totally dysregulate them and freak them out, right? And once I can assess that level of attachment, then I sort of know what I'm dealing with. And then this is so, so important. What do I do if I'm worried, right? As we talked about, do not feel embarrassed or alone. This is not your fault. You didn't make this happen. You weren't a bad parent, right? You didn't make this behavior occur, right? What actually you probably have done is you've raised a really strong, powerful girl that has turned on herself, right? And so we don't want to be alone with the worry, right? And again, I can't stress this enough. Move quickly, right? We don't want them sitting in this place for very long. Reach out to your pediatrician for an appointment. You have wonderful school psychologists at your school. Reach out to them immediately. That is a great resource. Not every school has that, right? So these are doctors that are going to be able to steer you in the right direction right away. The other thing to remember is that there are people trained in eating disorders, and those are the people to see, right? You don't want people to say, this isn't really a big deal. You don't want people to say, oh, I'm seeing so much of this these days. You want people to treat your daughter for what she is experiencing. And I put up on here books that I love, and I can also email these to Dr. Schwartz. I'm happy to, and Dr. Otero, you know, any resources that I have, any questions that we don't get to in this talk. And I will leave these up, and then I will stop sharing my screen. So I want to make sure, perfect, that we have about 15 minutes for questions, which we do. And that's really, that's it. So I am going to mute myself and then unshare the screen.
Thank you, Danielle. That was amazing. It's so informative. And we so appreciate you sharing all of this amazing knowledge. And as I mentioned at the beginning of the talk, please feel free to put your questions in the chat. We have a little bit of time. We see a few coming through, so please feel free to ask, and we'll get to as many of them as we can. Okay. So we have a question that came through, which is, what is behind the feeling / cause of being ashamed about eating?
Well, I'm ashamed. What is in terms of just like the relationship between eating and shame?
That's my guess.
Okay.
Can we perhaps talk a little bit more about that relationship?
Yeah, I mean, I would say for whatever reason, the way food has become in our culture is that you are stronger and more powerful if you are thin and if you have the ability to not eat, right? When the bread basket is on the table, if you don't need to eat the bread for whatever reason, that is associated with strength. It is inaccurate, obviously, but it is sort of a way, in my opinion, that women in particular, right, have come to view having power and having control. So I would say that's the relationship that sort of our society reinforces.
That makes a lot of sense.
Yeah.
Actually. Thank you so much, Danielle, for this talk. This was really informative and raised so many important thoughts and questions also for our community and our girls. We had another really interesting question commenting again on what an amazing presentation you gave. This is a very interesting question. What is the best approach for parents who see perhaps their overweight child continuing to overeat or make poor food choices, especially if they have underweight or normal weight siblings with whom they are sharing meals? And I think it's a layered and complicated question, but a very important one.
I agree. And I see this all the time. First of all, remember that all food is related, right? So an overeater is really running on the same frequency as an undereater, right? And so if you're seeing this play out over and over, I would say there are nutritionists, right, that really help families manage how to cope, right? Because I see so many families, right, where one child is like, have another, you're not finished yet. You need another, you didn't finish your meal. And out of the other side of the mouth, they're saying, you've had enough, right? So that is something we never want to do, right? Which I really is hard, but as parents, we need to sort of rein ourselves in and just think, okay, I'm not going to articulate don't and eat more. But what I'm going to do is say, like, everybody needs to eat, the chicken tonight, right? And sort of make it much more inclusive, right? And if it is something that you are really struggling with, then I definitely have many resources of family treatments, right? Because this is, if you have one in one direction and one in the other, it's really difficult for parents to manage on their own, right? And so that's something that I really want to validate as one of the hardest things to treat, right? And so I really get that. But there are definitely people that are very skilled in helping treat the family around food.
Thank you.
We have another really interesting question. As a parent, I am very focused on my kids eating healthy foods and checking ingredients. For example, we try to only eat gluten in 2 out of 3 meals a day. We eat protein with every meal, etc. In doing this, am I inadvertently teaching my kids to focus on food too much and risking them developing an eating disorder?
Honestly, I don't think it's great to be so stringent. I understand that as we get older, gluten becomes a very hot topic of discussion, but there is no real evidence that kids can't have a little bit of gluten, right? And so anytime we put kids in a position where they think a food is bad or a food is good, we are going to make them crave that food, right? So we want to keep the negative associations with certain foods down, right? And what you will find is the kids that aren't allowed to have sugar cereal, the kids that never have Doritos, those kinds of kids, not that I think Doritos are a great food group, but they are the first ones to eat an entire bag of Doritos the second they get their hands on them. Right? So normalizing is really what we want to do. Right? You should not have Doritos at every meal, but if you're serving a turkey sandwich on wheat bread, right, for lunch, a side of potato chips is actually really healthy, right? Because it's just normalizing all the food. And we don't want them sneaking foods that are considered off limits. That's really important.
Thank you. Mm-hmm. Just to ask a couple questions that came to mind for me. You mentioned a little bit of a link, which I think we're all aware of, between social media and the development of eating disorders. And I'm wondering if you have some thought on how to guide our girls in terms of how much time or what we should be steering them towards or away from on social media, and how to discuss that without making it sort of, in a topic that is, forbidden. So to make them want to go more onto those sites, what's a good way to manage that?
I mean, the way I really handle it in my practice is that I say all the time, like, that that's not real, right? Like we adults and grownups, we know that, right? We talk about that all the time, but teenagers, they know it, but they don't really know it, right? Because they don't really know a world without it. Right. And so if we really say to them, look, I am guaranteeing you that person has miserable days and days when she doesn't eat that perfect plate that is in front of you. So remember that what you're looking at is not real. Like I want you to, and obviously we can't really limit what sites they're going to. We can't really limit who they follow as much as we want to, but we can continue to pound into their heads that what they are looking at is not reality. Right? And discriminating social media from reality is very, very important. So that's how I usually handle that.
Thanks so much, Danielle. Can you talk a little bit about how parents can start the conversation if they start to feel concerned or start to notice some of the warning signs that you mentioned earlier in the presentation?
So, you don't want to come in too hot. I always say to parents, like, you want to come in at a medium temperature, but you want to say something like, I've noticed you're really particular about what you're eating these days. You don't want to use any language that's too big, right? And to say like, what's going on with that? Are you like freaked out about animals? Are you worried about hormones in food? Like, what is really the driving force between becoming vegan? Right now, with dramatic weight loss, you are much more explicit, which is like, you've lost a lot of weight. We got to go to the doctor. Right. And so the other thing that's important, by the way, is that if you have a child that's generally in the higher range of weight and you go to a pediatrician that is validating of the weight loss without really investigating the weight loss, then I would talk to somebody else. Right. Because again, just like therapists and psychologists, not everybody is trained in eating, and that includes pediatricians and adolescent medicine docs, right? And so I have met with so many girls that were initially validated by weight loss and then kept it up. But if initially that had been stopped, we probably wouldn't be so far down the path. So go in gentle, don't go in too hot, but don't ignore it, right? So using words like, I'm noticing, are you feeling okay? Or like, I noticed I never see Jen around anymore. What's up with her? Right? Where she disappeared, right? Or you're not going out on Friday nights anymore. What's up with that? Those are the gentle but probing, showing that you're paying attention.
Mm-hmm. That's excellent advice. Along those lines, how young is too young to start these conversations? When do we start as parents sort of having this be on our radar screen? And when do we start kind of engaging our kids in conversations about these kinds of topics so there's an awareness?
I think, again, you need to really know your daughter or know your kid. So because of puberty and when it hits, you really never know when your child is going to get activated. I've seen as young as 8, and then as old as 12, right? And then obviously much older. But if you know that your daughter has matured early, these issues come earlier, right? So you really, but it's funny, like when I lecture, and Dr. Schwartz and I talked about this too, like when I lecture to 5th, 6th, and 7th graders, the spectrum of development it's almost an impossible thing to navigate, right? Because everybody's at a different place in their development. So it really, you need to know your daughter and know when you start to feel like she's plugged in and she's noticing things that she didn't notice before. When she turns from a little kid into like a teenager-ish kid, that's when.
I think this is a similar question, Danielle, to some of what you've mentioned, but at what point do you recommend getting a professional involved, especially if your child is perhaps pretty resistant to some of those initial conversations, some of those conversations where you mentioned not coming in too hot? How do you balance kind of getting your child to engage, and also obviously, managing any concerns about her health?
I think a lot of parents can start by them going in to see an eating disorder person. I see a lot of parents before I see the daughter, or I'll work with parents alongside another clinician working with the daughter. So that way, in real time, they're sort of figuring out if there's a problem, if they have something to be concerned about. And then if they really believe there's a problem, having a therapist be a non-negotiable, right? Because there are really resistant kids out there. And you can have, if you find the right match, right? If there is a resistant kid, then something is going on, right? If you've identified that something is going on, then it is going on, right? So then it as a job as a parent is to find the right fit, right? Don't just say, she'll deal with this when she deals with this. You want to be proactive in finding the person that they will resonate with. And then as you described your daughter, if you're seeing a certain professional, as you describe your daughter, then that person will say, I know the right person, right? So it's keeping yourself engaged and you doing the work alongside the daughter. That's what I would say. Or son.
Thank you. I think this will be our last question to end with. I'm just going to generally ask you, Danielle, you're coming to speak to our girls the end of March. And I wondered if there was anything that you thought would be helpful or important for parents to mention or not in advance of your talk, or anything specific that you might want to mention that you will be sort of covering generally, so that we can be aware of that in advance of the conversation.
Well, I'm going to go over the genetic markers because I think girls don't know that. I think I want to go over that not all diets are created equal, and nor are people that use them. I usually really, really talk about social media a lot in these, and sort of really dive into why it's not real, and how harmful it is to not allow yourself like serious screen breaks. Right. And so what's it like for you to be with your friends and not be looking at what everyone else is doing? Right. So those are things that are really, really important. And then I like to talk about body image, right? And sort of what their ideas are about body image, how they have come to think of their own body image, and sort of what's important to them. Right. So those are the things I really want to cover, which is the factors. I also like to talk about stress and coping. Right? Because these high schoolers are right now in the crosshairs of stress, especially the juniors and the seniors, right? It's like SAT time, college admissions time, and sort of de-escalating the stress, and then talking about how food is not a great option for coping. And same with overexercise.
That's wonderful and so helpful. And I know you said you were going to have the girls have some opportunity for questions in advance, right? Yeah. Anonymous questions, which I think is going to be excellent. So just to remind parents of that will be available to the girls anonymously to be able to think through maybe in advance, which I think will be much appreciated. And then we'll cover those topics. So Thank you so much for this wonderfully informative and thoughtful and really important talk. I think it was wonderful, and you did a beautiful job, and I learned a lot. Good reminders, and a new term that might enter into the psychiatric diagnostic manual at some point. What is it? How do you pronounce it?
Orthorexia.
Orthorexia. Yes, that was new for me. So I definitely learned quite a bit from you. So thank you so much.
Thank you, Danielle.
It was my pleasure. Really, anytime.
Thank you to everyone for joining us. It's wonderful to have you tonight, and we look forward to future presentations.
Thank you, everyone. Have a wonderful evening.
Bye. Thank you.